and I'm really pleased to introduce Dr. Jehan Budak, is Assistant Medical Director of Madison Clinic and HIV Clinic at Harborview Medical Center. She's the Director of the Internal Medicine Residency Program, the HIV Pathway, and Associate Editor of the HIV Curriculum. She's interested in educational research regarding HIV/AIDS, with a particular interest in the effects of graduate medical education HIV-specific training tracks on the HIV provider workforce, and more broadly in creating and implementing curricula in different training environments and ascertaining how to most effectively train clinicians in HIV primary care. So you can see she's quite the expert to be able to help us learn more about HIV in older adults. Welcome, Dr. Budak.
Thank you, Barb, for the introduction. And here we go. So I will advance. I have no disclosures aside from the fact that I am not a geriatrician. I am an infectious disease doctor who cares for people with HIV. And as we will talk about, as the the patient population ages, we are seeing more and more older adults with HIV. And this is something that I am also working on. The objectives for today are to, for you, identify resources that can be helpful in the care of an older adult with HIV. And this is because I suspect that at least for most people in the Pacific Northwest or WAMI region, that there may be a person here or there with HIV, and that an HIV clinic is perhaps not potentially available for all of your patients, and really how to address caring for those patients and some resources that can be useful. So really hoping to equip you with some of the resources and knowledge to empower you to care for those individuals. To then describe the state of HIV epidemiology with a general update on ART so that you all have a sense of where we are with HIV, and to recognize the comorbid conditions that are common in older adults with HIV. I was sharing with Barb the other day that I think, especially as the patient population with HIV ages, that we will need some expertise from you all, from people who specialize in geriatric medicine and care for older adults. And especially, I oftentimes find myself referring for a consultation, and we are, I believe the entire field is eager to learn more and to better take care of older adults with HIV. So initially, I wanted to start off with some resources that you will hear me mention, but I wanted to encourage people to sort of have a frame for what it is I'm talking about. So the first one I wanted to mention is the National HIV Curriculum, then the HIV Medical Association's Primary Care Guidance, the UCSF's National Clinician Consultation Center, and last, a curriculum that might be helpful, which is the American Academy of HIV Medicine's National HIV and Aging Initiative. So first, this is the National HIV Curriculum, which is a HRSA funded, as what we also affectionately call it, and everyone calls it, online curriculum for HIV. It initially goes through ART. Here in the sort of second column is course modules. There's 6 different modules with tons of information. Some people go through it longitudinally, like a curriculum, followed by using the QBank to test themselves. I use it mostly as a resource because oftentimes I am seeing a patient and need a quick answer and will access it. We also have mini lectures that are about anywhere from 7 to 20 minutes in length. And then lastly, have some symptom guides, which I will share in further detail towards the end of this talk. This is the Joint HIV Medical Associations with the Infectious Disease Society of America's Primary Care Guidelines for persons with HIV that were published in 2020. There are about 33 pages that, again, are meant to be used as a resource, including having some tables for sort of what labs to obtain for initial visits, follow-up visits, etc. This here is another phenomenal resource, especially if you find yourself caring for someone with HIV and would love a little bit of quick guidance. They are grant funded. It's a national sort of center that is physically housed at UCSF, but is not necessarily UCSF's, and is a mostly a warm line where experts are available to answer questions. This is just a screenshot from their website, and we have access to people who can give about 5 to 10 minutes of telephone guidance on HIV and AIDS. Here you can see perinatal HIV and AIDS, Hep C. They have an addiction line, they have a pre-exposure line, and they have a post-exposure line. You can also email in questions, but I find that the sort of phone real time is perhaps most helpful. So I just wanted you all to be aware that that is a possibility. And then last, this is the American HIV Association's National HIV and Aging Initiative curriculum, which has many courses that you can take for CE credit if this is something of interest. So that's all the background about the potential resources that might be useful. So again, as I mentioned, I wanted to take you all through kind of where are we, what is the state of HIV, then talk about antiretroviral therapy, just so you have a sense not only of where we are, because it's clearly come a very long way from when HIV first started, but also recognizing that there are some medications which have side effects that affect especially older individuals. And then last, the majority of the session, I would like to talk about HIV and aging specifically. So HIV prevalence in the US, approximately 1.2 million individuals are living with HIV in the US. This entire talk is focused domestically, not globally. And of those 1.2 million, the vast majority, about 60% of them in America, acquire HIV by male-to-male sexual contact. HIV prevalence also varies throughout the United States. This is an image from a organization called AIDSview, a nonprofit that is housed at Emory in Atlanta. And they go through and keep this map and many other maps updated about HIV prevalence. And I think what I really want you to take away from this is that the vast majority of the epidemic is really in the South. And many of us, I think this is not something that's really known throughout the US as much, especially if you do not work in HIV, but I think there is a need there, and it is where the burden of disease is highest. As you can see, it is very dark down here in dark maroon. And then the other thing I wanted to mention is that back in 2019, there was a plan set out by the US government, which was a 10-year initiative to end the HIV epidemic in the US, which is affectionately shortened as EHE. They had 4 pillars. One was to focus initially on high incidence geographic areas, 2, emphasize early diagnosis, immediate treatment, and engagement, 3, have a rapid and overwhelming response to emerging HIV clusters, and 4, expand PrEP use to at-risk populations by at least 50%. And their overall goal over that decade, which again started in 2019, we now have 5 more years to go, is to decrease the sort of new cases of HIV by 90%. And there is a fair amount of grant funding that's going into this. And I mentioned the 4 pillars, but the 2 sort of really bedrocks of this is using treatment as prevention, i.e. getting HIV meds to those who need them so that we get their viral loads undetectable so that those individuals cannot transmit HIV. And then, and sorry if you hear the helicopter in the background, and the next one is pre-exposure prophylaxis, or the use of HIV medications to prevent HIV. I wanted to take this moment to just talk about pre-exposure prophylaxis, or PrEP. I think the vast majority of people hopefully have heard of this, but if not, I wanted to mention it and ensure that everyone is an ambassador for this. It is the strategy of taking antiretroviral medications to prevent HIV. In fact, is a grade A USPSTF recommendation and is something where you take a pill every day to prevent acquisition of HIV. There are 3 medications that are FDA approved. The first one was Truvada, or tenofovir disoproxil fumarate, and emtricitabine. You can see why, in general, I try to avoid using brand names, but when it comes to HIV medications, the brand names, because they're co-formulated, are really much easier to say. So in 2012, Truvada was FDA approved. Then in October 2019, tenofovir alafenamide, a newer version of tenofovir DF with emtricitabine or Descovy, was FDA approved. And then lastly, in 2021, an injectable every 2-month medication was approved to prevent HIV. These meds work if you take them. They are very effective at preventing HIV, especially for individuals who are at risk of acquisition. And what I really like about the new-ish CDC 2021 guidelines, which I have included a here in the bottom right-hand corner, a citation of, is that they say anyone who asks for PrEP should be given PrEP. That is because oftentimes we don't know all of the things that patients are doing and what potentially behaviors might put them at risk for acquisition of HIV. And so this is something that exists to help prevent HIV. The other thing I just wanted to sort of bring to people's attention is that in HIV, we think about care and in this thing called the HIV care continuum or the HIV care cascade. Here is from the hiv.gov that states that it's the steps that people with HIV take from diagnosis to achieving and maintaining viral suppression. And here, of people who are diagnosed with HIV, how many are linked to care, then how many receive medical care, how many are retained in medical care, and then how many achieve and maintain viral suppression. And so a lot of metrics, as you might imagine, across the US for HIV care are based on this HIV care cascade. And to show you where we are as a nation, I thought that this would be helpful, that nationwide, this is where the care continuum is that of all people who have HIV, 87% are diagnosed, that 66% of them are receiving care, 50% are retained in care, and 57% of those individuals are virally suppressed. And these are the numbers that people are trying to get closer to 90, 90, 90. If you ever hear people frame their conversations with regards to talking about HIV, it's that we're trying to get people to 90% for all of these, and especially viral suppression, because again, if we can suppress individuals, then it is far less likely that they will transmit HIV. And again, viral suppression here in the HIV care cascade is defined as a viral load less than 200 copies per milliliter. So a little bit of epi about people who are older. Approximately half of all persons with HIV are greater than 50. And here you'll see that on the x-axis, we have age in years, on the y-axis, persons with diagnosed HIV. And in the gold are individuals greater than 50, and that's 53.3% of the population, granted at the time that this graph was made, are greater than 50. And that's kind of different than the fact that most new diagnoses are in younger individuals. About 83% of people who are newly diagnosed are less than 50. And so I think what that means for individuals who are caring for older adults is that although the patient population with HIV is aging and growing older, we're going to see more and more individuals who are greater than 50, which I don't even think of as old, and that's where things are going to shift. But most new diagnoses are in younger individuals, so perhaps less so in the patient populations that you're seeing. That being said, I think this is interesting, that new diagnosis at an older age is associated with more advanced HIV. So though most new diagnoses are in younger individuals, when older individuals are being diagnosed, they tend to have more advanced HIV. And here is a graph, again, with age group on the x-axis, and on the y-axis showing the number of, or the percentage of individuals who actually have a stage 3, or what we call AIDS diagnosis at the time of diagnosis, is, as you can see, goes up as the age goes up. So people tend to have more AIDS if they are diagnosed at an older age. And again, AIDS is defined as a CD4 count less than 200. So the Lancet, the HIV in 2022 had a insert that was focused on aging with HIV, with a couple of opinion pieces and a few papers as well, in addition to the op-eds. And this was one that was talking just about delayed presentation of HIV among older individuals, this very concept that we were just talking about, stating that it's a growing problem. And a key point from this paper was that early diagnosis and treatment of HIV for older individuals is particularly challenging because early signs and symptoms might be attributed to diseases of aging, and because neither these individuals or their care providers perceive them to be at risk of HIV infection. So I think what one of the central tenets of this paper was that we are missing some individuals who are older. And so what are screening recommendations for HIV? So the CDC recommends screening all individuals aged 13 to 64, and the USPSTF TF recommends screening individuals aged 15 to 65 for HIV. And what about screening in individuals over 65? And I think this is a paper that was very timely that I saw this week and when preparing to give this talk, that was in the Washington Post, stating that the sexual health checkup older adults didn't know they needed because, again, their sort of punchline is that STD cases have risen among adults age 65 and older should you get screened. So granted, this paper, which I did not have access to because I do not have a Washington Post account, my guess is that their sense was that we should be screening more for STIs or sexually transmitted infections in older individuals, but we know that HIV is also sexually transmitted, and this is something that people should be screening for. And the Lancet HIV article posits that we should just be screening everyone, even individuals greater than 65, at least once for HIV. And also I thought this paper was very much in line with this sort of consideration to screen all individuals for HIV. I thought that I should take this opportunity to share a little bit about how to screen for HIV. There's many different modalities, and people have probably seen that there are rapid tests, which are great and can be sort of over the counter, or even perhaps at your sort of place of practice. But really the best way to screen for HIV is with a blood test using an HIV-1/2 antigen antibody immunoassay. It's too many words. It's just an HIV antigen antibody test. You might hear some people call it a fourth generation test. And this is really the sort of gold standard for how to screen. If it's negative for both antigen and antibodies, then it's negative. But if it's positive, then it reflexes to a antibody differentiation assay, because there is, although the vast majority of the world is HIV-1, there's a small subset, especially in West Africa, of a different sort of strain of HIV called HIV-2. And this will help sort of ascertain which HIV you have. Then if both are negative or indeterminate, it will reflex to an HIV viral load to ensure that we're not missing somebody with acute HIV. And if that's all negative, then you can assume that this antigen test was a false positive, which we do sometimes see. And especially with COVID vaccination or even COVID disease, we have been seeing more false positives. But that's not to say that there aren't also many true positives out there. And again, I wanted to sort of take this moment, it's a little bit of an aside, but just share the diagnostic test performances in acute HIV as a refresher for individuals to remember sort of how are these labs turning positive. So in the blue is the viral load, which can turn positive. I usually think, although it here is has an upward trajectory around 7 days, we think that we can probably pick up acute HIV with a viral load 7 to 10 days after acquisition. Then the P24 antigen, which is what is the antigen in the antigen antibody assay, will be picked up anywhere about 14 to 20 days. And then last is the antibody. And the reason why, when I was saying it's important to make sure that you're screening with that blood test, is that a lot of the rapid tests only screen for antibody. And at that point, you have a window period that's a couple of weeks long when you could actually miss someone who has acute HIV. So that was a little bit of background about HIV epi. And at this point, then let's take a bit of a transition into an ART therapy update, looking at the time. So as a reminder, 1981 was the first time AIDS cases were reported in the United States. And back, the first ART ever was in 1987, zidovudine, or AZT, which I think a lot of people have heard of. And I'm just showing this to you, not for anyone to memorize these medications, but to just recognize that we have come a really long way. And then even in the sort of last 10 years, things have really advanced. This here in 2013, dolutegravir came out, which is an integrase inhibitor that has a really high barrier to resistance, is well tolerated. And then 2018 was a big year for lots of medications. And it's just exciting that we have such an array of meds from which to choose. To sort of further prove that point, in case you don't believe me based on this image, here's another image from one of the AIDS education training consortiums that is a very helpful HIV medication chart that is available online. But again, just kind of gives you a sense of, wow, there are so many medications. I show this to contrast the fact that although there is like a panoply of medications, this is really all you need to know when you are starting somebody on HIV meds. And these are based on the Department of Health and Human Services ART guidelines, that the vast majority of people will start with 2 NRTIs, or nucleoside reverse transcriptase inhibitors, plus an integrase inhibitor. So that's it. So despite all of this, really it just comes down to having usually a combination pill like Truvada plus an integrase inhibitor. And then more recently, there is a push, and I would say this is really in the last 5 years, of people moving towards just 2 drug therapy here, which is 1 NRTI plus an INSTI. Nothing sort of significant for you to remember, but I wanted to sort of just mention that that is also something that's new. We have a question that says, are you seeing less adherence issues with the newer medications? Yes. And this is really what's, I think, fabulous about the new meds, is that they are getting smaller. They are having less side effects. They are easier to take. A lot of single tablet regimens that are 1 tablet once a day, and are really well tolerated. And I think that that has really helped with individuals and their adherence. That doesn't mean that we still don't have issues, but I think it has come a long way. I was not obviously around when the HIV epidemic first, well, I guess I was around, but I was not aware of it. And I'm very thankful that I practice in a time where there are so many medications from which we can choose that are really well tolerated. And as mentioned, there is a little bit of a push. Previously, that was all about 3 drugs is the key for antiretroviral therapy. Now we're moving more towards 2 drugs. It's not something that I think is correct for everyone. And in fact, it's really the minority of individuals who I think qualify for just 2 drugs, because you might imagine if someone's only going to take 2 drugs, they must make sure that they're taking it every single day. But I think it's really unique and cool that I think in the past 5 years and then the decades to come, we are going to see people trying to be more creative and minimize the number of medications that people are on to minimize toxicities, since again, people are living longer with this disease and thus are going to be exposed to these medications for longer. So this is just a table representation of essentially the sort of classes of meds that I'm just showing you here. But here is the first line recommendation is for a medication called bictegravir, tenofovir alafenamide, and emtricitabine, or Biktarvy. This is a small tablet once a day. And then the other one that we use the most of is dolutegravir plus either Truvada or Descovy. And here are the FDA-approved 2 drug regimens. There are 3 of them now. 2 of these regimens are 2 pills co-formulated as 1. And the coolest thing, I think, is that we have an injectable, a long-acting injectable. And this is something called Cabenuva, that is a combination of an integrase inhibitor and rilpivirine, which is an NNRTI, that can be given once every 2 months. And that's it. So people do not have to take a med every single day. People do not have to be reminded that they have HIV. There is, as you might imagine, a lot of stigma still with HIV, and I'm not going to go into that, nor do it enough justice, but there is unfortunately still stigma despite how far we have come. And I think that this is definitely something that can help individuals so that they don't either have to sort of carry their pills around so other people can see, or be reminded about this disease. And this is just a slide that says the long-acting injectables are the future. I think that the next few decades, I think for a while we were, and by we, I mean the HIV community, was really trying to find HIV meds that worked. Then I think the past decade or so was like, here are some medications that are well tolerated. Then the next decade, I think, is going to be, oh, wow, what are the kind of long-term effects from these meds, since people are living longer, and what are these other cooler, longer-acting ways of administering medications. And right now, there's 3 long-acting injectables that are FDA approved, 2 for treatment, 1 for prevention. I already mentioned Cabenuva, which is an intramuscular shot every 2 months. And then there's something called lenacapavir, which is a subcutaneous injection every 6 months that it has to be given in combination with orals, but is for multi-drug resistant HIV, but is really a game changer for individuals who have drug-resistant HIV and don't have that many options. And then there is cabotegravir or Apretude, which I mentioned earlier, which is used as pre-exposure prophylaxis. I think one thing that this will certainly help with is adherence. Clearly, at least with PrEP, it will help with adherence. And for right now, the way that the FDA has approved Cabenuva, the treatment, is that it has to be given for someone who is virally suppressed, is able to make their visits come in time. And I think we're a little bit nervous about giving it to people who have adherence issues. Now, I talk about this with patients where patients say like, hey, doesn't it make more sense to give somebody an injection who has a hard time taking pills? To which I say yes. But this medication, cabotegravir, is an integrase inhibitor. That is the workhorse. That is kind of like pretty much first line for everything. And if you develop resistance because we can't get a hold of that person or they're not coming in, then that has really untoward side effects. Right now, there's a big clinical trial that we are a site for. I'm referring patients all the time to get information on how is Cabenuva going to go in people with adherence issues. I think it's going to go well because I think that it is a way to get people engaged, get people taking medications, especially individuals who have had a hard time remembering to take them. So that's a little bit about that. And then the other big topic that I wanted to make sure people were aware of that has really been probably maybe almost the past decade is the concept of U equals U, or undetectable equals untransmittable. That's the concept that an individual with an undetectable HIV viral load cannot transmit HIV infection to their sexual partners. This is huge, as you might imagine, and is based on really these three sentinel studies that helped show that HIV, if suppressed, cannot be transmitted to one's sexual partner. This is very impactful for patients who have been nervous about having sex. And my hope and my guess is that especially even when caring for older adults, right, we want everyone to live their best sex life. And if individuals are not doing that because they are scared about giving HIV to someone else, then that's not their best sex life. And this is something that I counsel people about anytime I meet someone with new HIV. I talk about U equals U because it is powerful and I think it helps destigmatize HIV. I am not going to go into details about these three studies, but I did want to mention the Partner 2 study because this is actually one of the few studies that I will talk about the details with a patient, because in case any of you out there are wondering, is this really true? Can you really not transmit HIV if your viral load is undetectable? I think that the Partner 2 study will allay any of your concerns. This was a study in France of 972 serodiscordant men who have sex with men. So by that, I mean one man in the couple had HIV and the other did not, who were having anal receptive and insertive intercourse. And they were able to calculate that in this cohort, there were 76,000 condomless sex acts. And I tell this to patients because that's a lot of sex that was had. And in this patient population where one person had HIV and the partner did not, there were no HIV infections phylogenetically linked. So typically what happens is I'll tell a patient about U equals U, they'll be like, and then I tell them about Partner 2, and then they're usually like, oh, that's a lot of sex. Okay, I believe this. So that is the concept of U equals U. Okay, that was the quick sort of where are we with HIV? Before I move on to HIV and aging and take a quick peek at the time, I just did want to mention people might ask, what about cure or cure of HIV? Right now, there were at least 2 to 3 cure or patients who were cured, one of whom has since passed away. The first one being the Berlin patient, the second one being the London patient. And these are scenarios in which people ended up getting stem cell transplants for cancers that they had. And when they got their stem cell transplants, it was with a CCR5 delta mutant, mutation, like stem cell, basically meaning that these cells were had a mutation in the co-receptor that lets HIV bind and infect the cells. And they found individuals who had those CCR5 delta mutations, took their stem cells, gave them to these individuals, and because of that, they then, although had circulating HIV still in the system, could not enter the cells and thus were cured of HIV. When I talk with patients, patients ask about cure a lot, as you might imagine. I talk about how this is a big deal. Like people are like, can I get cured? And I'm like, well, if you got a cancer and then got a stem cell transplant, yes. And I think what's significant about this is that these are like kind of proof of concept that they exist. It's very, very scientifically cool. However, that's a lot to have usually a bloodborne or like a blood cancer, go through a stem cell transplant, take medications for that. And really you're sort of trading off one chronic issue for another. And so this is kind of how I share it with patients, but certainly scientifically very interesting and amazing that this occurred, but is not, as I like to tell patients, like ready for prime time, and is kind of a big deal. So that is the status of cure, in case anyone was wondering. So with HIV and aging, here are some principles about HIV in the older adult. And I just wanted to start off with some of these like key points just to frame the sort of rest of the talk. So older persons with HIV, and you'll see these abbreviations PWH, which again is person with HIV, have greater risk of developing non-AIDS complications than younger people with HIV. So, as people are getting older, the ART or antiretroviral therapy is working. People are getting less AIDS-defining illnesses and rather are now at greater risk of developing just complications. Older persons with HIV often have a blunted immune response to ART. As we know, HIV is a pro-inflammatory state. Antiretroviral therapy decreases the amount of virus around so that there's less inflammation going on. But even in the setting of an undetectable viral load, there's still background inflammation. And older individuals certainly respond to ART the same way. Their viral loads get down to undetectable, but the science has shown that there is a blunted immune response to antiretroviral therapy. That chronic HIV may cause accelerated development of comorbid conditions that are common in older persons. That persons greater than 50 may have a significant risk of HIV transmission due to unfavorable changes in mucosal surfaces and infrequent use of condoms. The infrequent use of condoms can be multifactorial, but one big issue is that sort of pregnancy is less of a concern as people get older. And as a result, less condoms might be being used. And so therefore more condomless sex is being had. And then these unfavorable changes in mucosal surfaces are likely sort of referring to the fact that things are getting drier and thus there could be more tearing or mucosal tearing leading to more, again, even microscopic bleeding. But when that occurs, that can sort of be a way that HIV can enter the body. And then lastly, that ART or antiretroviral therapy substantially reduces AIDS-related and non-AIDS-related mortality in older persons with HIV. So that's a little bit of the like, okay, where are we coming from with talking about HIV in the older adult? This is a graph talking about the viral response to ART in older adults. As I mentioned, if you are an older adult and you take your meds, your viral load suppresses. And this goes by age group on the x-axis, y-axis is percentage, and the blue is the number of people who are diagnosed. The gold is the number of people or the percentage of people who are getting care. And then green is a percentage of people who are virally suppressed. And I think just the takeaway point is that this slope goes up the older you get. And at least in my patient, or sort of in my panel, the 65-year-old is better at coming into their appointments and taking their meds than the 21-year-old is. And so that is kind of the takeaway from this. And then there's this concept of accelerated versus accentuated aging that I will talk about. And again, my disclosures are again that I'm not a geriatrician. I get like nervous when talking about frailty in front of people who are geriatric specialists. And so if these are terms that everyone already knows, then please sort of disregard my comments. But the concept of accelerated and accentuated aging, accelerated being that people are sort of aging faster or sort of aging occurs more quickly, versus accentuated being is that when it occurs, it's happening in a worse fashion. And so the sort of, I think, based on my reading and understanding, is that with HIV, there is both accelerated and accentuated aging. That not only does it move up aging, as this graph suggests, that sort of aging at an earlier age, but it's also aging in a perhaps worse way. And then here's frailty. I had to include this, obviously. Frailty occurs earlier in people with HIV, sort of, again, consistent with this whole accelerated aging concept. And I thought that this was a pretty confusing graph from this review article. And so in an effort to make it less confusing, I've added boxes, which may be a bit hard for the eye. But I have, in the boxes sort of denote individuals with HIV, and they're comparing individuals with HIV to individuals without HIV. And as you can see, the sort of dark bars are pre-frail and frail, and that there is more frailty in people with HIV, and that it's occurring earlier. And here also similarly, frailty occurs more frequently in people with HIV from the same review article. And I thought a little bit easier to see that in those with HIV are the dark bars, and the light bars are those who do not have HIV, and that there is a higher prevalence of unintentional weight loss, weakness, exhaustion, slowness, and low physical activity in persons with HIV. The other thing that I think is worth knowing is that life expectancy in HIV is similar to the general population. I recognize that this was not always the case, but now it is. I was looking at some other papers that were showing that really it's just a couple of years difference, persons with HIV having a little bit less than the general population, but generally very similar. Obviously, that is sort of supposing that people are taking their ART and have viral suppression. So here is a graphic from the National HIV Curriculum. In this top bar is persons without HIV with a life expectancy of 79. And then here's the life expectancy of someone who, let's say, acquired HIV at age 20 and is taking current antiretroviral medications. Their life expectancy is 71, which is quite close to 79. And then here is someone who is not taking their antiretroviral medications, where the life expectancy is much, much shorter. Now, whenever I have a patient who's new with HIV, my spiel includes the fact that the meds work really well, that people end up living with HIV for longer, and that people die, and I don't really exactly say it in these words. I try to be a bit more sort of gentle with it, but that people are dying from other things. People are dying from their diabetes, from their heart disease, which certainly HIV is a component or contributor of, which I will share in the coming slides, but that it's not that, and that we have really, again, come so far that people are living longer, living almost as long as people without HIV, and the other things end up being a bigger issue than the HIV itself. Polypharmacy, as you might imagine, is prevalent in older persons with HIV, also prevalent in younger persons with HIV, because again, at the very least, this individual is usually taking 3 different medications, oftentimes co-formulated as a single tablet regimen, but living with taking these meds for a very long time. And thus, it is no surprise that as people age, that polypharmacy is quite prevalent. And here is an image with the number of co-medicines on the x-axis and the percent of patients on the y-axis, showing amongst persons with HIV, that in addition to their ART, although the vast majority of individuals are not taking zero or not taking any other meds, that there is a fair amount of co-medicines in addition to that. The other thing sort of to be aware of with antiretroviral therapy is drug-drug interactions. There are many, but I wanted to highlight a couple of them that are big ones. So cations, polyvalent cations, calcium, iron, magnesium, can bind to and chelate certain integrase inhibitors. So dolutegravir, bictegravir, again, the workhorses of our antiretroviral therapy. So I know that calcium is often taken for bone health, and iron oftentimes is taken as well. And so when this is the case, we really are counseling patients to separate them. There's usually a couple of hours from which you need to separate them for maximal absorption. And oftentimes I'll tell people, just take your HIV meds in the morning and take your, vitamins in the evening. But this is a big issue that I think many people are not aware of. The other one, I think my nemesis in a clinic is our antacids, and specifically with certain meds, and specifically with rilpivirine, which is one of the medications in the 2-drug combinations that a lot of people do take, and H2 blockers and proton pump inhibitors can inactivate rilpivirine, which requires an acidic environment for absorption. I have been taking famotidine for a decade. I know that people pop Tums here and there, and so this is very important, and especially as people age, to sort of be aware of. If you see somebody with HIV, just take stock of their other co-medications in case it is interfering with their ART. And then the other big one, which hopefully we don't have to see as much of anymore, is the pharmacologic boosters that are needed with the protease inhibitors. That is a class of antiretroviral therapy meds, the protease inhibitors, which are older, that are very robust, have a very high barrier to resistance, but require pharmacologic boosting. And those boosters are ritonavir and cobicistat, and those actually inhibit CYP3A4. And so you can imagine that there are many, many drug-drug interactions with those. So those are just a couple of examples of some drug interactions. And the website that I primarily use for this, and I wanted to highlight as a resource, in addition to using the National HIV Curriculum, which has a section on antiretroviral therapy, drug-drug interactions. This I use pretty much on a daily basis. It comes out of the University of Liverpool in England. They actually have a Hep C drug interaction checker and a COVID drug interaction checker. As you can see, they're advertising that here in the green. But basically on the left-hand side, you put in the HIV drug. Here is cobicistat co-formulated with darunavir, which is a protease inhibitor and a pharmacologic booster with fluticasone or Flonase. And here it says do not co-administer it because the darunavir and cobicistat can raise the levels of the fluticasone. And we have seen cases where people have developed a Cushing syndrome from just their inhaled nasal, their nasal corticosteroid. So hopefully I have put a little bit of fear in everyone that these drug interactions can occur with seemingly very benign medications, including a nasal steroid, injected steroid into a knee. And so when you see somebody with HIV, just please use resources, communicate with a pharmacist. And I can only imagine that as people age, we see it a lot in clinic, that people are just going to accrue more and more medications. The other thing to sort of be aware of with antiretrovirals is that, as I mentioned earlier, they have adverse effects. So tenofovir disoproxil fumarate, or TDF, which is in the NRTI class, is notoriously for its bone demineralization and its nephrotoxicity. We, as a result, check a creatinine every 6 months and then get a DEXA scan on every person with HIV who's greater than 50 as ways to mitigate this. But these are very real and potential side effects from TDF, which is a backbone of most medications. There are less bone and kidney issues with tenofovir alafenamide, or TAF, which is what's in Descovy, as compared to Truvada, which contains TDF. TAF is a prodrug of TDF and so has less of these issues, but nonetheless is an issue. And I have a colleague who works at the VA and has an older patient population, and he uses a lot more TAF based on the age of his patients. He does not necessarily switch to TAF at a certain age, but certainly when someone is greater than 65, I know his practice is to sort of reassess, say, should I get this person on TAF instead of TDF, given kidney issues, given bone issues? Now, a downside of TAF and then a downside of the integrase inhibitors is weight gain. I will talk about that in a couple of slides when we talk about comorbidities in HIV, but that is something to be aware of. Cardiovascular risk is an issue, especially with abacavir. We are not using abacavir as much, but is a medication that can cause cardiovascular disease. And then hyperlipidemia we see with tenofovir alafenamide and darunavir again being the protease inhibitor class. So there are things that we are giving to patients that are causing them to gain weight, that are causing them to have high cholesterol, and then also causing them to, once they've gained weight, oftentimes develop diabetes, and to which we have to add more medications, and that begets a problem. Like one problem begets another. So that's that. The other thing, just so that you are aware of, is that there are some of the HIV medications that have benign effects of ART on creatinine. So these are not things for you to remember, aside from the fact that, one time Jehan mentioned that there are some antiretrovirals that can cause a benign elevation in creatinine without affecting the GFR. So the ones are bictegravir, cobicistat, dolutegravir, rilpivirine, and actually this is how trimethoprim, which is in Bactrim, works, and they inhibit proximal tubular secretion of creatinine, which again increases the serum creatinine, but does not change the GFR. So it's really just a sort of false reading on the lab because the creatinine is not being peed out, but it's staying in the plasma. And so as a result, you may expect a 10 to 20% increase in creatinine, usually within the first few weeks of therapy, and then that plateaus. And so our practice is anytime we're starting one of these medications, we have a person come back in a month because we want to check and make sure that their viral load is suppressed after starting a medication anew or switching a medication. And then we also get a creatinine to see what their new baseline is. And so this is something for you to be aware of, because I'm sure, especially as people age, we may see more increases in creatinine. The other thing is that and again, this is something that I will not do justice in this talk because it's a lot of things to talk about, but that persons with HIV tend to have more risk factors for comorbidities. That in addition to the HIV, there is a fair amount of depression and anxiety in the patient population. Substance use is commonly seen. Again, not in everybody, but just like these are comorbidities that we see in clinic, that health disparities exist and contribute, that co-infections can cause some comorbid conditions or problems. I already mentioned the side effects from ART, and then there's also the stigma that I've sort of touched on, and the impact of living with a chronic disease. Let me try, I'm stuck. Here we go. And then the other thing to sort of be aware is that cardiovascular and cancer-related deaths are on the rise in persons with HIV. This is a graph that has the year of death on the x-axis, that the y-axis is percentage of all deaths. And here in the blue, you'll see that the HIV-related deaths are decreasing, which is wonderful because we have ART. People are getting suppressed and are living longer, but as a result, people are acquiring cardiovascular disease and cancers, and those are, again, HIV-related things are still higher, but we are seeing more and more cardiovascular and cancer-related deaths in people with HIV. This is just a image to show that the overall and comorbidity-free survival in persons with HIV is less. So if this is a study this is a Kaiser study, and on the y-axis is expected time remaining at age 21 of life. And then here's the study years. But basically, if you can just sort of look at these titles on the right, the top is without HIV infection, and then with HIV infection. So if you have HIV, it's sort of your survival is a little bit less. We've talked about that with life expectancy. But then here, without HIV, you have more comorbid free years, whereas with HIV, you tend to have less comorbid free years. Sort of leading us to the next slide, which shows that people with HIV have higher rates of comorbidities. In the blue, the dark blue, sorry, that's all blue. In the dark blue is HIV, and in the light blue is no HIV. And you'll see here that persons with HIV have higher rates of cardiovascular disease, kidney disease, liver disease, and cancer than those without. This is just another image to show that multimorbidity is rising in persons with HIV. Here are the years, again, on the x-axis. The y-axis is percentage of individuals in HIV care with age-associated conditions. And then here are the colors of their conditions. If you have one condition, it's red, blue 2, green 3. And so you'll just see that people are getting more and more issues. And I think this is something that is seen obviously in patients who are aging, but it's also just seen in persons with HIV. So you can imagine the sort of combo of the two is additive. So I wanted to finish off with, and we still have obviously about 20 more minutes about the multimorbidity in HIV. And I highlight this, again, I can't talk about everything, but I wanted to highlight some key issues that you might come across when you are seeing somebody with HIV, or you are being asked to consult on somebody with HIV, or just caring for anyone with HIV, and just to be aware of these things. So I thought we could highlight weight gain, cardiovascular disease, renal disease, neurocognitive decline, cancer, osteoporosis, and testosterone deficiency. So just a couple slides on each of these. I already alluded to the fact that weight gain is a thing, and I find personally this is interesting because I got to see it, hence this chronology. But I will highlight that in 2019 at our big conference on retroviruses and opportunistic infections, it was that an association between INSTIs and weight gain was reported. And all of us were like, these are all retrospective, that's interesting. And the thought at that time was perhaps this is more so with dolutegravir. Again, a lot of us were like, these are all associative papers, nothing was causative. America tends to be a little bit larger. What's going on? And we started counseling patients about this association. But again, it was just kind of early on. Then we got data from sub-Saharan Africa and from a randomized control trial. And they found that the combination of TAF FTC or Descovy plus dolutegravir led to the most weight gain. Then in 2020 at the International AIDS Society conference, we learned from an American cohort that weight gain in persons with HIV switching from Truvada to TAF was most pronounced that occurred, and that really occurred in the first 9 months after switch. So people would kind of go up and then plateau thereafter. And then at ID Week 2020, there was another study that found that switching from the older version of tenofovir to the newer version was associated with more weight gain than switching from abacavir to the new version of tenofovir. And that's significant because people walked away from that being like, is TDF keeping people smaller, or is it sort of helping people lose weight or stay smaller, again, from a weight perspective? And really, based on this study, people started talking about, are the medications obesogenic? Or is it that we're sort of taking away anorectic medications? And the theory is that TDF actually has some mitochondrial toxicity and was helping people was actually like eating up some cells and causing some weight loss. And so they were sort of removing an anorectic agent, and then are they gaining weight because of that, or are they gaining weight because it's really obesogenic? So I think that this is very interesting. I certainly have these conversations with people where I'm like, do you want to maybe lose a kilo and maybe have bone and renal toxicity, or are you okay with that? And this is certainly part of the shared decision-making when I am talking with patients about starting antiretroviral therapy. And then this was a pooled analysis of 8 ART randomized controlled trials. And I'll just take you through this, where on the x-axis is the number of weeks into therapy, and then the weight in kilograms gain, a weight change, is on the y-axis. And this far left graph shows that the integrase inhibitors in red were associated with more weight gain, which we've already talked about, right? Dolutegravir is one of those, is it that class? And so that was more so than with the protease inhibitors of the NNRTIs. And then this middle graph is showing that bictegravir and dolutegravir were, again, these are the INSTIs that we use all the time, are more associated with weight gain than the older elvitegravir in green. And then on the right, they looked at the NRTIs comparing AZT to TDF, again, tenofovir disoproxil fumarate, to abacavir and TAF. And here you can see that the TDF and the zidovudine kind of like maybe plateau here. This one definitely led to some weight loss, and that it's the TAF that's associated with the most weight gain. And I thought this was a nice image that weight gain is multifactorial. Certainly there's a lot of contributions from diet, activity, environment, host, habits, mental health, but that antiretrovirals and HIV are potentially contributing. One theory is too that the integrase inhibitors get so well into the adipose tissue even that it is killing HIV in the adipose tissue, which then is potentially letting people have more sort of those adipose tissues are enjoying that and growing. But it's interesting because, we are doing this to people. We are giving them medications that are certainly life sustaining, but they are associated with some weight changes. And also the integrase inhibitors are independently associated with diabetes. And then now people want medications like Ozempic or Wegovy with the GLP-1 agonists, and our insurance is not covering it. And so it feels crummy as a provider. But again, really sort of highlights how far we have come with antiretroviral therapy. So that's one big thing. And I bring that up because you might see individuals who are gaining weight, getting more issues with hyperlipidemia, diabetes, and then having the issues from those. Then cardiovascular disease. Persons with HIV have a higher risk of cardiovascular disease, both in men and women, but sort of really high, sort of potentiated in women. And this on the y-axis is the relative risk with HIV versus someone who's HIV negative. And the blue are men, the sort of red are women. And you'll see that there's higher rates of myocardial infarction compared to persons without HIV, stroke, and heart failure. And it's, again, potentiated in women. Their increased risk of cardiovascular disease in persons with HIV is multifactorial. There is certainly the component of traditional risk, that inflammation, as we talked about, in immune activation from the HIV, ART risk. I mentioned abacavir, but also darunavir is associated with increased cardiovascular disease. And then what is the contribution of insulin resistance, potentially from the integrase inhibitors, dyslipidemia, also from our medications. So again, it is multifactorial. And I wanted to highlight that there is a circulation AHA statement on the characteristics, prevention, and management of cardiovascular disease in people living with HIV, so that if anyone needs to access this resource, recognize that it exists. And then as far as management of cardiovascular disease in persons with HIV, we try to start ART as soon as possible to decrease inflammation, check lipids, and the primary care guidelines for HIV-MA suggest checking it at baseline, then either every 5 years if normal or every 6 to 12 months if abnormal, to calculate an ASCVD and start a statin if appropriate. And here I wrote perhaps at lower percentages, again, because perhaps the ASCVD risk is a little at lower percentages, we should start statins in person with HIV because of the higher cardiovascular risk. That again, as always, be aware of drug-drug interactions. Protease inhibitors and NNRTIs with statins are problematic, but in general, atorvastatin, pitavastatin, and rosuvastatin are okay. Nothing for people to remember, just again, drug-drug interactions are real in antiretroviral therapy. And then we try to do the usual, discuss smoking cessation, blood pressure control, diet, and exercise. Renal disease, I just want to highlight a couple of things. This is a nice resource from the New England Journal about kidney diseases associated with HIV, if anyone is interested. Common causes of CKD in people with HIV are, I wrote, the usual causes, including non-ART medication side effects, i.e. ibuprofen, et cetera. Hep B or C, HIVAN, which luckily we don't see a lot of anymore, but is nephrotic range proteinuria in individuals not on antiretroviral therapy. And then I had previously mentioned tenofovir-associated nephrotoxicity, and that is usually due to TDF more than TAF, may or may not reverse with drug discontinuation, and potentially could be a higher risk with ritonavir boosting medications, and that the use of tenofovir can lead to any of the following. It can just cause a GFR decline, proteinuria, a proximal tubulopathy, or a Fanconi syndrome, which is the type 2 renal tubular acidosis. And then here, the diagnostic workup of creatinine elevation in persons with HIV that I recommend is to consider a benign ART effect. I'm not going to read these because, again, this will be a resource for you. But so consider benign ART effect. Did the creatinine just go up because this is what the drug does? Is it a tenofovir effect? Is it a non-HIV related cause? Again, hypertension, diabetes are becoming increasingly common in persons with HIV. And then to send a diagnostic workup if you are really worried. That was a quick breeze through renal disease. I think neurocognitive decline, again, I'm speaking to bunch of experts about this, but at least with regards to HIV, it is multifactorial. I thought that this very recent paper highlighted how multifactorial neurocognitive decline is in persons with HIV, as I recognize that it probably is in everybody, but also specifically persons with HIV having specific contributions from the HIV itself, whether it be from the ART, the viral loads, latent reservoirs, neuroinflammation, host demographic factors, host behaviors, comorbidities, whether it be a non-HIV related comorbidity or an opportunistic infection in the CNS. And then lastly, neurologic assessment methods. To sort of, again, as a resource, we have on the National HIV curriculum these symptom guides, and I wanted to highlight the Memory Changes Symptom Guide, which takes you through, it's 4 pages about like what to do with regards to memory changes in HIV, because I oftentimes deal with this in clinic and find myself a little bit stymied when it comes to memory changes. I will print this out and make sure that I'm following it. And so these are the questions that we recommend asking. What is the most recent CD4 cell count, i.e. does this person have advanced HIV? Might they have an OI or an opportunistic infection? Is the person taking a medication known to cause neurologic or cognitive side effects? Has syphilis testing been performed? That's a whole talk in and of itself, but obviously neurosyphilis, which can occur at any stage of HIV, or sorry, of syphilis, can lead to neurocog issues. Are there associated symptoms that suggest a metabolic, toxic, or psychiatric disorder? Are there signs or symptoms that suggest obstructive sleep apnea? Because there's a fair amount of OSA in HIV. And lastly, could HIV itself be the cause? These are images from those symptom guides of the diagnostic approach and what to do. And I wanted to sort of let you all know that the wording is, or the sort of what we are calling this is HIV-associated neurocognitive disorders, or HAND, and that's a spectrum of disorders due to HIV that can cause cognitive decline. That HIV-associated dementia is the most severe of the HIV-associated neurocognitive disorders, and there's an international HIV dementia scale that might be useful in diagnosis. In late in 2023, the International HIV Cognition Working Group actually suggested moving away from HAND towards HABI, which I think is cute, HIV-associated brain injury, which includes HAND, includes HAD, but also incorporates multimorbidity better. It's saying that there's all these other things that could be contributing to this. And usually there's not a whole lot that can be done. I tend to then refer somebody to a brain and wellness center or a memory care clinic. But what I try to make sure that I'm doing is that I'm treating the HIV. In most current, in fact, all current ART have really good CNS penetration. So we don't really have to worry about the HIV escaping into the CNS, which can happen, but again, is extraordinarily rare. And there's no data to support intensifying ART if the person's already suppressed. Cancer is on the rise in people with HIV, but the epi is changing. In red are the non-AIDS defining cancers, in yellow are the AIDS defining cancers, and on the x-axis is the years. And as you can see, the AIDS defining cancers are decreasing, but in red, non-AIDS defining cancers are rising. And here is a table of cancer screening in persons with HIV. I think the things I want to highlight is that we see in people with HIV, there's more anal cancer and more cervical cancer. A lot of that because it's HPV mediated, and certainly there's like more virally mediated cancers in HIV. But there was a big study that came out about 2 years ago that showed that there's benefit to screening for anal dysplasia. And so anal PAPs are being done with more regularity. The risks for colon, lung, prostate cancer, and breast cancer sort of currently recommend that the screening should be the same as it is for someone without HIV. And then cervical cancer screening is certainly complex in persons with HIV. I look it up each time. And this is all to say I've sort of written like each different recommendation based on the age of the individual. But all this to say is that with HIV, most people will need a PAP with HPV co-test. So we're doing co-testing right off the bat, that we never stop screening. So whereas in women or cisgen, rather, in persons with vaginas or cervixes, the recommendation is to stop at 65. But in persons with HIV with a cervix or vagina, we continue screening forever. And then the abnormal PAP and or HPV results follow-up is different as well. osteoporosis, we're just got about a couple more minutes left, is quite interesting in HIV. I think that osteoporosis is more common in persons with HIV compared to age-matched individuals without HIV. That persons with HIV have a higher risk of low bone mineral density and fragility fractures. And the reasons for this are multifactorial, or as are the reasons for everything. But the ART contributes. As we've already talked about, TDF is not great for the bones, and protease inhibitors also can sort of affect bone health. That ART initiation, specifically with these meds, can lead to a 2 to 6% loss in bone mineral density during the first 2 years of therapy. And then what I think is really fascinating is that HIV itself can infect osteoclasts, turning them on and increasing bone resorption. So I think that is a little bit newer, that came out in 2018, and I think is really interesting and unfortunate. That there's also an increased risk of osteoporosis with hepatitis C, which we commonly see in persons with HIV. And then just like regarding bone health in general, unrelated to osteoporosis, persons with HIV are at an increased risk of avascular necrosis. So we see a fair amount of that, especially in young individuals, but that's something to be aware of, is that when you're seeing somebody with HIV with potentially hip pain, shoulder pain, and those are typically the areas I see it, that avascular necrosis is a real issue in patients with HIV. Independently, HIV is a risk factor for it, and I have young individuals with joint replacements, which will then need to be dealt with as they age. Again, the etiologies are multifactorial. There are very nice 2015 guidelines for evaluation and management of bone disease in HIV. And the management of this is that we are intended or recommended to get DEXA screening in all men with HIV who are greater than 50 and all postmenopausal women. That we should optimize ART if possible, that if we have osteopenia or porosis, to avoid the protease inhibitors and TDF if possible. And switching from TDF to TAF leads to improvements in bone mineral density. But in osteoporosis, that it's okay to use TAF, or we can switch to an entirely tenofovir sparing regimen, because we now know that we have 2 drug regimens we can use, and that the treatment for osteopenia or porosis is similar to how it's done for the general population. And then lastly, testosterone deficiency. I just have this on one slide. That you might have heard that people say, oh, there's more testosterone deficiency in persons with HIV. And this might have been true, and specifically is rooted in data from early in the AIDS epidemic. In 1988, there was a small cohort of men and with HIV, with AIDS, and had wasting, and they found that 50% of them had a low diagnosis of low T. And then more recently, in 2014, there was a US study of 530 men, and laboratory confirmed low T was found in 9.3% of persons with HIV, as compared to 7.2% in matched HIV negative controls. And then interestingly, among persons with HIV who initiated testosterone, only 24% had laboratory confirmed testosterone deficiency. So when to screen, I screen in men with HIV if they have symptoms that are suggestive of low T. But otherwise, I'm not screening across the board. When people come to me and say, oh, I have HIV, so I have lower testosterone, that is not really the case, especially based on this more recent study that showed that low T levels were relatively similar. But the key thing with testosterone deficiency is that if you're screening for it in someone with HIV, that obviously it should be a fasting AM, but the blood draw should be a free and total testosterone. And that's because HIV can increase sex hormone binding globulin concentrations, which can then lead to a falsely elevated total T. And hence, it is important to also get a free T in persons with HIV. So the hype didn't really bear out. Relatively similar rates to persons without HIV, maybe a little bit higher, and that if you're screening for testosterone deficiency in persons with HIV, to get a free and total level. So in conclusion, people with HIV are living longer and growing older. Greater than 50% of persons with HIV are over 50, and we will be relying on you all on this call for your help and guidance, and look forward to working with you. Not to forget to screen older adults for STIs and HIV, and that persons with HIV may have accelerated and accentuated aging, more frailty, more multimorbidity, and polypharmacy. And that lastly, it felt a little cheesy to put on a bullet, but I think we've come a really long way with HIV. And I'm excited for the next decade to see, especially with these long-acting injectables, reaching people who have been traditionally hard to reach. And I think it is an exciting time to begin HIV, and I wanted to share some of the advancements with you all. So thank you for listening.
Thank you so much. This was great. I learned so much. I really appreciated the focus on polypharmacy and multimorbidity in older adults because that was new information for me. We do have a question coming here. Mary Zeitner is asking, is it true or an urban legend? Let me see if I can get to the, might have been a GEC talk that we had in the 80s and HIV in older adults. Older people do acquire HIV. A 65-year-old woman came into the ED with nonspecific flu-like symptoms. She requested to be tested for HIV, but was denied that. Some length of time later, she died of AIDS. It turned out that she was a sex worker, but had never been asked. Thoughts about those kinds of biases in older adults? Are you still seeing those?
Yeah, I mean, my hope is not, but obviously I think I live and work in a progressive city where people are, I mean, and even in those scenarios, there's a lot of stigma still. I think one thing that is great in the state of Washington is that we no longer need, like, I think previously in the order sets, it's like, have you gotten consent for this? Obviously, we should always be getting consent from patients for anything that we're going to test for. But I think that that barrier sends this subliminal message that it's like, intense to screen for HIV or not. And that's not the case. And I think if somebody asks for HIV testing, if somebody asks for PrEP, I think we should be, as providers, decreasing barriers. I think especially with older individuals, I have heard of people who are 85 and getting diagnosed for the first time. I think and those are the rare scenarios at like a conference, people will talk about this, but nonetheless, it exists. And I think we, in the medical field, can sort of bring these things up because I think a lot of patients are nervous to talk about it or hesitant to talk about it. And I think if we bring it up with people, we normalize it and make things like screening for STIs and screening for HIV less scary. And I'm really sad to hear that story, Mary. It's probably true, sadly.
Even now.
Even yeah.
Yeah. You and I were talking when we were doing, I think, the speaker test about the considerations for older adults and primary care. And does primary care sort of occur or provided by the HIV specialist with referrals out or vice versa? And what would you recommend people think about in that regard?
I think it really depends on where you're located and where you're providing care. So, I currently work at Harborview, and I work in a big HIV clinic. We have 4,500 patients with HIV. We are a medical home, so I am providing their HIV primary care and HIV care. I admit I am not the best at a shoulder exam. I used to be better, so I certainly recognize my deficiencies. And similarly, I think, Barbara, I was telling you that sometimes I have somebody who is older and I would love a geriatrician or a sort of geri clinic to just like see the patient, have a one-time consultation, give me guidance on ways that I can improve things. And so I think that that is something that we're going to see a lot more of. Again, I'm in a specialized clinic in a big city. I think for people who are in more rural locations, if you are interacting with somebody with HIV, or not even rural, but you just don't have access to a big clinic, there are many different models. Some ID doctors will sort of act as the person's HIV primary care provider as well. Historically, that was because, as you might imagine, due to stigma, people did not want to see people with HIV. And so their ID doctors ended up being their primary care doctors. Now that is easier for the patient to go to one place, but it really depends on the clinic. So I think, and then the provider. So I think I know that we are talking to a broad audience today. So I think it really depends on where you are, and to sort of not be afraid to ask those questions of whomever and saying like, oh, is your clinic caring for everything else? Or would they benefit from seeing us? And again, there are lots of different resources. I think the clinician consultation center is helpful if you are sort of like, I'm taking care of this person, help. There are echoes, or, the sort of Project Echo, the telemedicine for HIV. We have that for the 5-state WWAMI region. So if anyone is caring for someone with HIV and wants to learn more, that is a way that they can sort of access care. So I think, Barb, that was a very long-winded way to say it really depends. There's many different models.
Are you, for example, for rural areas or very distant areas, do you do telehealth kinds of consultations, or how does that work?
It again depends. I think we have in the again the Echo family. There's a pretty broad network of people who are HIV specialists, and then I think usually what ends up happening is that people are referred to a bigger city for at least some care. But it's also, I think we also have to recognize that there's not a lot of HIV in some rural areas. I worked in North Idaho for a year and told everyone I knew that I had a specialty in HIV, and people were like, I haven't seen someone with HIV in 15 years. So it really depends. Also, are people really screening everywhere? Who knows? So maybe the people with HIV are there but aren't being screened. And so I think there is no current telehealth model, but there is telesupport for the providers
Gotcha.
who are working with individuals with HIV.